why traditional quality improvement approaches just aren't moving the needle the way we hoped. Joining me is someone who's been tackling this issue from every angle: clinician, educator, leader, and system thinker, Dr. Rob Flora. Dr. Flora is the Chief Academic Officer and Vice President of Academic Affairs at McLaren Healthcare, and he's also a professor at Michigan State University in both the College of Human Medicine and the College of Osteopathic Medicine. He's a fellowship-trained urogynecologist, a former chief medical officer, and an unabashed advocate for getting quality improvement out of the ivory tower and into the messy, complex world of real-life health delivery. His perspective weaves together frontline care, academic medicine, health disparities, and even engineering logic models. Seriously, Dr. Flora has built a QI framework modeled after a circuit board. Today, we're diving into why cookie-cutter QI efforts often fail, how structural and social determinants of health are routinely ignored in improvement models, and what healthcare leaders should be doing instead. So if you've ever sat through a PDSA cycle that went absolutely nowhere, or worse, checked all the boxes but changed nothing, this episode is for you. Let's jump in. Welcome to PEMBA On Demand, Physician Leaders Making a Difference. I'm Norm Chapin, your host. PEMBA On Demand is produced for physicians seeking professional development. We discuss a wide range of topics on the podcast, including successful innovations in a variety of healthcare disciplines, current issues in healthcare career development, and healthcare leadership. I will be interviewing physician leaders from the U.S. and from other countries, most of whom graduated from the Physician Executive MBA program at the University of Tennessee. The information provided in this podcast is for general informational purposes only and does not constitute professional advice. The views and opinions expressed by the host and guests are their own and do not necessarily reflect the views of the University of Tennessee or any other organization. By listening to this podcast, you acknowledge and agree to these terms. Whether you're sipping your morning coffee, commuting to the hospital, or just looking for a dose of inspiration, we've got you covered. We hope you will take full advantage of these practical, insightful, and relevant discussions designed to help physician leaders get new and build upon existing leadership skills and perspectives. PEMBA On Demand will allow you to be an even bigger force for good in healthcare. Welcome to another episode of PEMBA On Demand. I'm glad you could join us today. I'm pleased to have as my guest today Dr. Robert Flora. Rob is the Chief Academic Officer for McLaren Health Systems in Flint, Michigan. And Rob is going to be talking to us today about why standard QI won't work in healthcare. So Rob, welcome to the show.
Thank you very much, Norm.
I really appreciate you taking time out of your busy schedule to join us. I've been looking forward to hearing your presentation and asking you a few questions about it. But I thought maybe to start, you and I have known each other for a long time. We used to work at McLaren together. But I'd be interested to know, at what point in your career did you decide to pursue the MBA at the University of Tennessee? And what was the main motivation for that?
Well, it's actually an interesting story. I grew up in a small of 10,000 people, and my father was the only OB-GYN in town. My mother, who was a nurse, ran my dad's practice. And I guess ever since I was 2, 3 years old, I always said I wanted to be a physician. And I used to help my mom in the office. I was about 16 years old. My mom turns to me and says, if you want to be a physician, you need to learn the business of medicine. And from that point on, she kind of mentored me. I'd help them with the books. I'd help them clean the office. I just do anything just to kind of understand the culture in an office. And they had a very nice culture there. I mean, small town. He couldn't walk into a Walmart with half the people stopping him saying, hey, you delivered me, or here's my son you delivered, or you took care of my mom. So it was what people called the good old days, I guess, in medicine.
Well, it's interesting. I didn't realize or didn't remember that your dad was a physician. I grew up in a very similar situation. My dad was the only primary care physician in a small town in the Thumb area of Michigan. And I used to work in his office all the time as well. Became interested very early on in medicine. So it's interesting how our backgrounds are not too dissimilar, I guess.
Yeah. And I think the value of seeing what our fathers experience. Obviously, things have changed, but I still feel that that kind of value and service we provide is still paramount to, how we perform as physicians.
I agree. I agree. Well, I'm excited to have you on the show. I'd like to sort of give you an opportunity to do your presentation, and then maybe we can come back at the end and I'll have a few more questions about the information that you present. So I will turn it over to you right now with your slides.
So I came to this talk because of numerous events in my education and career. So I actually started at Michigan with the idea that I wasn't sure about medical school. So I actually studied biophysics and engineering science at U of M, and really learned about system thinking very early on in my education. I kind of was waffling again about medicine, and finally my dad said, it's harder to get into medical school now. You need to just go ahead and apply. So I did, and noticed that medical school is quite different. It's a lot of memorization. You just have this large volume of material you have to learn. So you couldn't really take time to really understand thoroughly the inner workings of how medicine is provided in the United States. And so over the years, I did my MBA at PEMBA. And one of my classmates, Anita Rowland, had said, you may want to get an MPH because it's where you learn the concepts of population health as well as policy. And Anita had done a MPH prior to her MBA. And so because of that, I did complete the MPH. I did a patient safety fellowship. And because of all of this, as well as being a CMO for a managed Medicaid company, running a residency program, trying to teach residents the best way to prepare for medicine in the United States, it kind of evolved into this concept of how quality improvement does and doesn't help where we need to go. And what I would tell you is I attribute a lot of this to PEMBA. Dr. Leiter got me started and had bought all his textbooks. And then Chuck Noon, who's an engineer and one of the faculty, also gave me the ability to put engineering and systems thinking with healthcare. And so very early on, I just developed this different view of quality improvement in healthcare. So what I'm going to touch on, and this is a part of a bigger presentation that I've given nationally, I'm going to describe the history of American medicine. And the reason for that is to understand how medical education changed after the Flexner Report kind of also gives a history of how quality improvement in healthcare developed. So we'll talk about how QI started in healthcare and how it's evolved so far. And then because, as I promised, that the PDSA is not going to be the only approach that's going to really improve healthcare, then I'm going to make some recommendations on how to adapt based on my experiences. So the question is, how did we get to this point? So I developed this graphic based on numerous articles, historical text on how we got to the Flexner Report. And how it started was in the mid 17th century, there was a Oxford circle of scientists that really started pushing the science behind healthcare. And in the United States, there was a group of 4 people that was watching what Oxford circle was doing. And so this Hopkins circle developed, and they said, how could we improve the medical education program in the United States? And one of the members of that group was Abraham Flexner, who was an educational teacher, not a physician. There was funding from the Carnegie Foundation and the Rockefeller Foundation, and that led to the 1910 Flexner Report. But what influenced Flexner quite a lot was that he was very enthralled with the German medical education system, which was really a hyper-rationalized form of medical education, which was really just pure science. And so when the Flexner Report came out, it had a lot of aspects of that hyper-rationalized approach to medicine. And then as things occur in a society based on capitalism, there was a lot of influences that led to the post-Flexner American medical education system, with the approach really being it's all about the science and less about the art. And so the medical education system evolved about science and research. And a lot of the culture also had many aspects built into it. For example, patients were lucky to see us as opposed to we were lucky to serve the patients. The term ivory tower was actually from William Osler, and he called the scientists and physicians in the ivory tower clinical prigs. There also then became this hierarchy that developed within different types of healthcare providers, where you can see academicians were looked at a higher level than clinicians. Allopathy was looked higher than osteopathy or homeopathy. And then specialists were viewed at a higher level than generalists. And the ideal position during this then was based on the three-legged stool that you were a clinician, you were a researcher, and you were an educator. And so the scientific method became ingrained into the way we look at how medicine should be provided. And the scientific method, as we all learned it in grade school, middle school, or high school, and it's how we've gotten to where we are. But it really is not the only approach that we have to incorporate. So what happened was that healthcare really became the wild, wild west. And as time has progressed, we've noticed that healthcare has become more complex. So again, when my father and Norm's father grew up, they were mom and pop shops. And as we see consolidation of physician practices in the hospital, private equity, the complexity of healthcare has changed so much that something as simple as a PDSA cycle, which still will work in a mom and pop shop type practice, will not be as effective in the current healthcare environment. So one of the things that I learned very early on through the quality improvement training was Dr. Deming's lens of profound knowledge. And as you can see, it's also called the life of your change gets messy. And what I found was that trying to affect change in a system is definitely not as easy as people think. So, in engineering school, we were taught, okay, you have this light go through a prism, what's to change? And, you could predict those things. When you try to change something as complex as the healthcare system, and it goes through these components of the lens of profound knowledge, you can't really predict what light comes out through that lens. And so the PDSA cycle and the way we currently approach things will not really address all of those issues. And the other problem that I saw is that we kind of saw a flavor of the year through the past years. There was Lean and then Six Sigma. There was all these types of quality improvement approaches that developed since, when I started out, it was all about quality assurance. But when we brought these companies in, yes, everybody got trained, and then everything kind of petered out. People would leave. People, if you're not using these skills on a regular basis, kind of degrades. And so we have gotten to the point where we don't really have a good approach other than the PDSA. Now, one thing, and we're starting to see this now, is that William Osler was one of the four on that Hopkins circle. And the thing that bothered him the most was it was about the science, but they really forgot about the patient. And one of the things that I noticed is that the way medical education was, it focused on symptoms. And if you just focus on symptoms, it doesn't really help you get to the root of the problem in terms of improving healthcare. So here you can see the statement, the good physician treats the disease, the great physician treats the patient who has the disease. And that's where you're starting to notice a shift where we're focusing on social and structural determinants of health. We're starting to screen on inpatients as required by CMS for at least the start of disparities. And as healthcare progresses, we'll learn more and more about how to get to those root cause problems. But the way healthcare is set up right now, it's so complex that it's not going to be an easy push unless we have approach that I'll mention that will address these changes in a way that hopefully we make some impact in our activities. So medicine is an art and a science. And so what we need is to make sure we bring the art of being holistically looking at our patients. And what we're doing in residency programs is, since 2013, requiring quality improvement training. And the reason for that is that residents come in to be developed in terms of a certain specific knowledge, internal medicine, family medicine. But residents now are also be trained in an additional science called the science of improvement, which is what we're discussing today. So I'm a history buff. Always like to see how the things started. And so I backtracked again and looked at how did quality improvement, the movement, start in healthcare. And so when you look back at history, there was three key figures: Florence Nightingale, Dr. Semmelweis, and Ernest Codman, who really was instrumental in developing the American College of Surgeons and, I believe, Joint Commissions. And then we started looking at healthcare in a more structured manner. And so Dr. Donabedian, a pediatrician, this is a quote: "Ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system." And so in 1966, he came out with the assessment of quality of care we now call the Donabedian model, where we started focusing on, if we're going to improve healthcare, then we need to look at the structure of how we provide care, the processes of that care is provided, and then outcomes. And his outcomes were morbidity, mortality, and satisfaction. So again, the Demings, the Durans, how that started was them, after World War II, coming over to Japan and helping Japan with their quality improvement, mostly with the car industries, though other industries were also involved. And what's interesting is that Deming used to have these seminars. He would come back and forth between Japan and the United States. And I guess Don Berwick attended one of his seminars. And when he attended it, he called some of his colleagues, I think Dr. Batalden was then in, and said, "You have to go to this workshop." Now, Dr. Berwick also had influence from Joseph Durant. So you can see that 1950s, 1960s influence in quality improvement came over from Japan through these giants in quality improvement. So then the question is, how did the PDSA get into healthcare quality improvement? So this started out through Walter Schuhart, so where Schuhart curve or graph, and he was really leading the push on statistical process control. And so through that, Deming learned and developed the PDSA, which I believe started as the PDCA. And then from there, Don Wheeler took that and developed the concept of 4 process states. So the 4 process states, this is a graphic that shows the concept of Dr. Wheeler. And basically the y-axis says is, do you have processes in control or do you have processes out of control? And then the x-axis says, do you have 100% conformity with that process or do you have some non-compliance or conformity? And if you look at healthcare, we have a lot of non-conformity in the sense that there's evidence-based medicine, evidence-based practice, but we know within 6 years, 50% of it's wrong or has to be modified. We have people that don't really keep up in the literature and what's going on in terms of changes in healthcare. And with the doubling time of 73 days now for medical knowledge, it's very easy for people to fall out what the plan should be. So when you look at these 4 boxes, what I would say is that healthcare in the United States especially is in a state of chaos. And when you have this state, it is much more complex to fix than using a PDSA approach. So Schuhart had said that statistical process control requires a stable process. And, so that's how you determine whether there's common cause or special cause variation. Also, you have to be able to identify when a process becomes unstable. You must be able to differentiate a signal versus noise. Then you also need to understand that culture can eat statistical process control for breakfast. And Deming had a concept of unknowns and unknowables. And with that, again, applying the straight statistical process control is not really as helpful as everybody feels. So the point that I show to the residents when I do the boot camp with them at QI is that you can't take an assembly line approach, which is the PDCA, PDSA, to patient care, because we know that patient is in a car, isn't built the same through the assembly line. They have their differences. They react to medication different. There are things related to their age, their race, et cetera, that make the variation higher than you would with a car. And so when I was continuing to learn more about quality improvement, I actually came across this book called the 7 Steps Method. And really, it came from a book that Dr. Shiba wrote called A New Paradigm Total Quality Management, or TQM. What I was really impressed with was that the 7 steps really tie statistical tools, which are called the 7 tools. And so really it started in the 70s in Japan, but didn't come to the United States until the early 90s, when many huge corporations said, we have to have a better way to approach our industry. And that was how the 7 steps, 7 tools was born in the United States. And the interesting thing that he pointed out was that there are different types of problems or gaps that are addressed by quality improvement. So control problems are problems where you have a standard. So you're on a car assembly line. One step goes out of specification. So the end product is not coming out perfect. So what do? You go in, you investigate, you find where the point in the line has gotten out of specs, you fix it, and you're back in control. When you look at healthcare, we have a different type of problem. They're called reactive problems. And so because we have so many ways of doing things, there is no true process that's out there. And at best, evidence-based medicine and guidelines are what they are. They're guidelines. And again, with the change over time, and you can go from one hospital to another, and you really will see a variation in how they approach things. That in healthcare in general, there is no good standardized process. And one of the things that I've noticed is that when people are trying to do QI, they get into this mindset that they have to standardize everything. And again, when you're dealing with patients, because there's such a variation within the patient, I have a saying that you can only really standardize the best and individualize the rest. And what I find is it follows the Pareto 80-20 rule. So you can really only standardize 80% of what we do. You have to give that physician the ability to modify the care based on that specific patient. And so, like I said, we have the approach to reactive problems introduced to the 90s. Many other industries out there are now past that and are into proactive problem solving. So healthcare has quite a lot to go. So again, this gives you a kind of a timeline. 50s and 60s are the PDCA, PDSA. The 70s, so again, in the US, the 1990s, it's the 7 steps, 7 tools. And then quality function and deployment and 7 quality management planning tools are from the 80s.
This podcast is sponsored by the Physician Executive MBA program at the University of Tennessee, Knoxville's Haslam College of Business. In less than 1 calendar year, this program will equip you with valuable business acumen and leadership development not found in traditional medical school curriculum. Are you ready to join the longest-running physician-only MBA program in the country and a network of nearly 1,000 PEMBA graduates? Visit tiny.utk.edu/POD podcast for information about this exciting opportunity. And now we'll return to the episode. wonder if I could just ask one quick question
Sure.
about it. Came to mind as you were talking. Are there processes in healthcare that you would say lend themselves to sort of a manufacturing approach for
Oh,
improvement?
absolutely. So when you look at what the ACGME expects residents to be taught and to what they're able to do, they should be able to look at their current practices and analyze it through a quality lens and change their practice to improve the care they provide to the patient. Now, what's happened in healthcare is that I tell the residents this, they have a grade card for the rest of their life. And what that grade card is basically pay for performance. So you practice for a year with Medicare and then you're in the MIPS program. And so I always forget now, about 45% of their score is quality or those improvement activities, 2, 3, or 4 that they have to do a year. CMS gives you 100 to choose from. That's very easy to do the PDSA. And so that's where we really focus the learning on with the residents. We want to make sure that they're successful. Nobody wants to be the person who CMS says you're in the bottom decile in the country. You're going to get 9% less than everybody else for the next year. We don't want our residents to, in practice, experience that in practice. So yes, there are times, but when you start when you were CMO and in my position, we got handed more complex problems. And so what I tell the residents is hopefully you move up to positions of leadership. And then you need to learn these other tools that we teach them. And what we do is we make them leave our institution with all the tools, 7 steps, 7 tools. And I tell them it's going to be a while, but there's a point you're going to say, I got to find those templates that Flora had. And what I tell them is look me up on Facebook or Indeed, or not Indeed, but any of the other online services and say, email me or text me and say, hey, Flora, you were right. But it's going to happen. We're now, have moved into downside risk. There's just too many things happening in healthcare that you have to be able to not only stay above the benchmark, but surpass it.
Great. Thanks. Sorry to interrupt that, but I
No,
didn't want to
that's
forget
good.
the question.
No. And it's actually a great question. And that's why we give these templates out.
Great.
So it may sound like I'm a anti-vax, whatever you want to call it, but all Sheba really did was he made the PDSA more granular. And what I mean by that was that he broke the 4 parts of that cycle into 7 steps. And by breaking those 7 steps down, he also then said, okay, you have to have the data to make a informed decision on how you're going to fix something. And first of all, the other thing I tell the residents is that we get this mindset developed in medical school that most of us aren't aware of. And that is we're the consummate black and white thinkers. So when I normally put a problem in front of the residents, they'll say, oh, that's easy to fix without really thinking it through. And I joke that things had to be fixed in an office, that they're hotel guests in the office, the people that really know what's going on in the office are the staff. And when physicians try to change things in the office, it usually doesn't work. But the point is that when we have residents do QI projects, they don't really analyze it. And QI is basically the scientific method. It's just wrapped in a different package. But they don't really focus on the data, and they don't focus on it like it's teamwork. I always tell the residents, I don't want you doing QI projects with just other residents or other physicians, because the nurses, the respiratory therapists, et cetera, anybody involved in taking care of that patient adds value to the knowledge and the care of that patient. So you can see here that we have the tools tied to which step. And that when we have our QI summits and we have presentations and we judge them, we actually look for these kind of things like aim statement, which tools did they use? And so it really enhances the possibility of success in changing. The thing that has helped me the most when I work with residents is actually the cause and effect diagram, where they start understanding that there's more than one reason why things happen. And we're starting to push the residents now where I don't allow residents to do a project with a bunch of residents, because what they do is they divide up the pieces. And if you look at the ACGME data, only 3% of residents have ever gone through a complete QI cycle, and only 8% of residents, when they graduate, feel that they have adequate knowledge to do this. And so by really emphasizing this different approach, again, if they move up to positions of leadership, they'll be more apt to be able to deal with more complex problems because, Norm, as a CMO, there's never one reason for anything. Now, the other thing that I started looking at, and now this is starting to delve into some of the public health background that I developed after I got my MBA, is that I started really rethinking about disobedience outcome. Because in public health, outcomes are divided more into short-term, medium-term, and long-term outcomes. And so what we really do in healthcare when we fix something, you fix a process, and this is the output of that change in the process. And outcome does not really develop until down the road. And usually we say 3 to 5 years, where you're really starting to impact things like patient outcomes, accessibility, et cetera, et cetera. The little things that we do are really outputs. And the ideal thing is that when I updated the Donabedian method, that I changed the circle there from outcomes to output, because how you really get movement is by having different outputs, addressing different aspects of the problem, work toward the long-term outcome. So what you can see here is in public health, we look at short-term outcome as, awareness, education, attitude, and that the medium-term outcomes are based on what we've done, that we're changing the behavior of the people providing the care, but not only the people providing the care, but the people receiving the care. And it's only then that you really start changing behavior. Then you start working to the long-term effects. So better population health in a certain group, more equitable care, more inclusivity. And again, the residents come out and they think, okay, I did this great project. We increase it from 30 to 50%, and then it kind of dies on the vine. University of Michigan is the first that I know of that started a master's and PhD program on implementation and outcomes, because doing the quality improvement project is one thing, but we know that there's this regression to the mean where they want to go back to the old way. And so it's a certain type of knowledge and skill to keep pushing it so it sticks. And so the program for master's is 2 years. And I believe, like any PhD, it's 5 years at Michigan. So having taken all this experience and knowledge that I've gained, I've actually developed my own approach to fixing things because, again, growing up, a hospital is a hospital. There was hardly any alignment. And now you've seen what's happening in Michigan, around the country, about consolidation of health systems. And when you have seen one hospital and how they do things, you've seen one hospital and how they do things. And even within the 13 hospitals within the McLaren system, just the initial pilot was with obstetrical care. We see variation in such a significant amount, even in terms of how up to date the care is in that specific hospital. And so it really is very complex. And this is where the public health field, where they use their logic model and have a big picture, medium picture, small picture view of the problem, makes it at least hopefully more successful at dealing with the issue. So this hybrid approach, as you can see here, includes, again, the logic models from public health. Actually, for my electrical engineering classes, we are learning about parallel and series circuits. And I put that approach in terms of how parallel QI programs toward the same issue, or quality improvement with improvement, and then you continue to work on improving that cycle. That's quality improvement in series. And so what we've done is kind of define how to approach quality improvement at a bigger level. Obviously, organizational psych, dealing with the lens of profound knowledge. Again, total quality management, introducing the 7-step 7 tools. And then all the newer things that have come out with from patient safety literature. So high reliability, applying system engineering. And then education is a major component. And so we really stress in McLaren intra and inter-system collaborative improvement through education. Yeah, I have a saying, Joint Commissions is always saying, you got to be a learning organization. You got to be a learning organization. I came into McLaren, and what I said at the beginning was, you can't be a learning organization until you're a teaching organization. And so all the things that I've been involved in change incorporates teaching the lessons that we learn and disseminate them so that we improve the care in our system. So this is an example. So we use this approach with quality, multiple quality improvements is system series, parallel parts, and I termed it the 2S, 2P approach. And so this is the way that we're structuring the resident QI projects. We have a patient safety dashboard. Norma is very aware of that. Now we have a high reliability dashboard. And so from October to September, the health system picks priorities on what they want to address during that fiscal year. And so what we do is that safety dashboard, those two dashboards get disseminated and reviewed pretty much every month in the system. So I tell the residents, well, first of all, we teach the residents about it. And we say, okay, look at what the priorities are for the system this year. Because if you tie your project to one of the priorities, not only are you more apt to get some attention from the administration, you're more apt to get resources, and there's probably activity already going on that you can hook onto or even develop from it. So here you can see with this nesting that the priorities, which is more the series type approach, is connected with the parallel approach of different QI projects addressing the same ultimate problem, but addressing a factor in the fishbone diagram. So if I can just mention that we are about 2 years into the obstetric initiative project, and ultimately the whole idea was that the system would set up the parameters and this is the evidence-based way of doing it. We would pass it down to the subsidiary hospitals and say, okay, this is what the evidence says. How are you doing it there? And then we receive feedback from it. Well, we do it this way, we do it that way. We have committees looking at care and other components of it. I'm on the education component. And then as a system, we decide with input, and we know that within McLaren, there's variation at all the sites. So you can't replicate things at a rural hospital that you can do at our bigger hospitals. And so this rapid nested cycle, we try to look at it as every 3-month cycles where we approach something. So we did hemorrhage, then we did hypertension. It takes a little bit longer in a system that doesn't really understand QI. So we slowed down a bit, but I think we're getting to the point where the system's starting to understand it. So they're my pilot, and my next project is trying to work with a health plan that McLaren owns. I actually own 2 health plans, and use this system because they have pay for performance and they need to have quality improvement initiatives in place, normally related to social determinants of health and other things, and that their revenue is at risk if they don't have their grade card and try to get the best grade on it.
So this has been a great presentation, Rob. Thanks very much for this.
Thank you.
I've learned a lot from just listening to you talk, and not just during this presentation, but previous relationship. But a couple of questions. You focused a lot how you're training the residents to become physician leaders, and you talked about what you learned in your MPH and your MBA program. But how do physician leaders who've been through an MBA program or an MPH or quality and safety training, how do we, when we're in our roles as chief medical officers or chief physician executives, CEOs, how do we train physicians to think about QI in this way when they haven't had the advantage of going through their training program and being exposed to these concepts?
So, Norm, as you know, we're part of Southeast Michigan Center for Medical Education. And I used to teach for the AAMC, the Teach for Quality program. And this is about 2015. And when I went there, I learned it was kind of hard to teach people to teach something they didn't know themselves. And so you're exactly right. That's one of the problems. We started basic and advanced QI boot camps through SEMCME. And then I actually have done a quality improvement for program directors, faculty, and fellows. And we've had 2 medical schools already take advantage of that. So there's a AAMC paper that shows the gaps in terms of faculty knowledge and where it needs to be addressed. And so we've taken that and used that data to develop this course. In fact, we started a full 6-month faculty development series for our new faculty and program directors at McLaren. And one of the things is scholarly activity as part of that. So I'll be honest, I've always said this, it's going to take about 2 generations of physicians being trained to really move the dial, but we're starting.
I noticed too on the graph where you talked about the 7 process or the 7 tools, there still are a lot of tools that come out of the models that Deming, Duran, and Schuhart had developed. So and if I'm starting a QI program and I'm trying to deal with a complex issue, what guidance would you give in terms of determining what tools are going to be the most effective? Does your training include that for the residents?
So we actually tell them that these 7 tools are just the beginning. And I have a bunch of pocket things that list 100 and so tools or more that are out there. But again, we're just getting them to the level of being competent at basic QI. Just like when we went on in practice, we had to continue learning, right? So that ability to become proficient and possibly even expert at that has to be done when they're out of our wings. And that's where we develop these templates. And somebody like a CMO, and we've actually used them when they're approached with a problem like that, we say, hey, use this template. And it basically walks you through the process. But to be honest with you, one of the biggest things that we start with the physicians is to tell them to stop thinking like a doctor. So again, we are black and white thinkers. We are convergent thinkers. And the physicians that we're trying to develop are convergent, divergent thinkers and leaders of the healthcare team. So what I mean by that is that they will lead the team in divergent thinking, come up with different ways that we're going to approach this. And then as the physician leader, they're going to go through each one and then converge on the best choice for the patient with as much input from the team as possible. So what I would say is that with these complex problems, you learn from the team and they help you. But the template is the beginning and it kind of gets the wheels rolling.
I wonder too, if you could talk a little bit. I know you're an upstreamist by nature. You like to figure out root causes. But I wonder, historically, I think in medicine and healthcare, focused on those things that we have control over. How do we reduce surgical site infections? How do we improve the number of labs or samples that get to the lab properly labeled? All of those types of things. But I get a sense that you feel that there's a bigger challenge in front of us today, and that is, how do we step outside of our bricks and mortar facilities and really start focusing on improvement? And maybe you were alluding to that a little bit in the proactive phase of what we're going to do. But I wonder if you could speak a little bit to that and what you see for the future and how this training would help physicians focus in that way.
So again, I think ultimately physicians are naturally physician scientists. That's just the way we're brought up. So what I tell the residents is that, and this is Aristotle saying, is that quality has to be a habit. And so that's one of the first things, is that you have to look now through a lens. Basically, the IOM has said that, make it more efficient, more timely, et cetera, et cetera. But it's not as hard as people think to actually fix things. And it's just a matter of wanting to do it. Like I give the example, golf. We all want to golf. We all want to be like Tiger, and we all know we have ups and downs. But I tell the residents the first time when you get out, you may do a QI project and maybe a little bit sketchy. The next time you do it, it's going to get a little bit better. Because the other thing we tell is learn from the last project. And again, it's really more about changing the way you look at things. And again, because the way we're developed as physician scientists, we know the scientific method, it'll just come. And I tell the residents, you don't apply it just in your job. You apply it in your personal life, because everybody talks about work-life balance. That's impossible, because you just within your lifespan, you're going to go through different phases. So what you do is you take quality improvement and apply it on both aspects of your life so you can get what's called integration. And I've done that myself personally. I've had residents that do it. The other thing that we do, that we focus on the softer skills. So if you remember, all our residents get crucial conversations and crucial accountability training, because communication is the biggest factor in terms of patient errors and et cetera. So we don't just develop them in terms of their QI ability. So they go through team steps, they go through the communication things. We put them through mindfulness so that they're mentally set to deal with that. And they have to be able to adapt to change. I think that's the biggest thing.
Thanks for that answer. I guess the last question, because I know we're running out of time a little bit here, but you mentioned Don Leiter before, and I know Don was very involved in quality improvement, process improvement, and there's many, many agencies and awards now that are focused on organizations that achieve great quality improvement. The Joint Commission has kind of tried to transition itself into being an organization supportive of improvement and high reliability organizing. Do you see those efforts as being beneficial in healthcare? Do they help us focus on the right things?
Well, I wouldn't necessarily think that it's having us focus on the right things. If you look at the resources they provide, I feel it provides a start. Like, so for the IHI model, it teaches them how to look at a problem and come up with that aim state. But again, I do utilize their tools, but what I do understand is that it's not going to be the end all. And if you look at IHI, then they have those development programs where you're developing the champions in the system to do that. So to be honest, the IHI material just to teach QI is good enough. But what they're really working toward is getting that culture change. And those programs are expensive, believe me. I mean, I think you're talking about 10,000, but a health system, if it really doesn't pay lip service to this stuff, should be willing to invest to get people trained to really be the champions in their system. And unfortunately, because of COVID and how healthcare is going, we're all doing more than our job. And so it gets hard. But if you can partition time for somebody to focus on it, and guarantee you that there will be changes.
Well, this has been a great conversation, Rob. I really appreciate you taking the time to join me today. I feel like we could record 3 or 4 podcasts and just scratch the surface of everything.
Oh, yeah. This is very complex.
Yes. Yeah. So maybe we will have you back on the show for another episode. I know there's a lot of areas that you have focused on and that you worked on to improve not only the residency education at McLaren, but just the quality and safety and high reliability in that organization. So I really appreciate all those efforts for the patients and for the physicians in the organization.
Well, yes, thank you for having me as a guest, and go PEMBA.
Go PEMBA. Thanks again for joining us on this episode of PEMBA On Demand. Today, we had the pleasure of hearing from Dr. Rob Flora, a deeply experienced physician leader, educator, and systems thinker who challenged us to rethink the foundations of quality improvement in healthcare. We explored the historical roots of American medical education and how the legacy of the Flexner Report and the hyper-scientific model of care has shaped today's physician mindset. Dr. Flora helped us to see why traditional tools like the PDSA cycle, while helpful in small-scale settings, often may fall short when applied to complex healthcare systems. Dr. Flora shared his hybrid 2S2P model using parallel and series QI cycles, logic models, and systems engineering, offering a more realistic path forward for large organizations. We also discussed the importance of upstream thinking, cultural humility, and integrating social determinants of health into the improvement process. And we touched on how physician leaders, especially those who weren't trained in QI, can still foster a culture of continuous improvement and collaborative learning. If you're a physician executive trying to lead real change, this episode reminded us that it's not just about having the tools, it's about having the mindset, the team, and the adaptability to address problems that are anything but linear. Thanks again to Dr. Flora for an inspiring and thought-provoking conversation, and thanks to you, our listeners, for spending time with us. Be sure to subscribe and join us next time on PEMBA On Demand. Until then, lead well, keep learning, and take good care. PEMBA On Demand is released bi-weekly, every other Thursday, and available on Apple Podcasts, Spotify, Castos, or Overcast. Please subscribe to the podcast on your favorite podcast player by clicking the subscribe button. Add PEMBA On Demand to your podcast library today. I would also appreciate it if you could share the podcast with your friends or colleagues. You can also listen to our podcasts on our YouTube channel, www.youtube.com/@PEMBAON-demand, all one word, no spaces. Please hit the like button and subscribe. Also, if you have any comments or questions regarding this or other episodes, please feel free to add them into the comment section on our YouTube channel. We love hearing from you and are happy to answer any questions you may have. I will add a link to our website and our YouTube channel in the show notes. The website is tiny.utk.edu/PEMBA On Demand, all one word. There's no hyphen in that URL. You will find the links to the episodes there. Please also check the show notes for links that were discussed in the show today. Take good care of yourselves and become an even bigger force for good in healthcare.